Okay, so we are on the last section of Unit 8, which is care of the patient with musculoskeletal disorders. Part 3 will cover osteoarthritis and the arthroplasty surgeries, total hip arthroplasty and total knee. And I have page numbers down in the bottom right-hand corner. Osteoarthritis is actually a very small section of Chapter 39. They grouped it with the rheumatic disorders, even though osteoarthritis is not a rheumatic or autoimmune disorder at all. It's a degenerative joint disease. And then for the hip arthroplasty and knee arthroplasty, we'll be looking at pages 1117 to 1129. So we'll go ahead and get started, and then you guys will be finished with this content and ready for exam 3 in the final. Osteoarthritis is a degenerative joint disease, and unlike rheumatoid arthritis, it is not caused by an autoimmune disorder or generalized inflammation, although in later stages it can include some inflammation. I'm going to just kind of move this picture up here and blow it up so you can see. The normal joint has two bones that are joined together with articular cartilage right here on the ends, okay, and it should be nice and smooth. And there should be a fair amount of synovial fluid that lubricates that joint and causes smooth movement when that joint is moved through its range of motion. Now, with age and with high impact activities, let me see if I can just kind of bring that down and blow it up a little bit. What happens is that the synovial fluid decreases, and then we have degeneration of that cartilage. It starts to wear down or break down. And even though the body will try to replace it, it doesn't replace it as quickly as it needs to. The destruction happens faster. And so we get bone spurs. Let's see if I can, there we go. Or osteophytes. It's just another word for bone spur. These are kind of sharp, jagged edges, and they have the potential to rub on the articulating cartilage of the next surface and cause more damage. So it's not really just a simple wear and tear kind of explanation there. There is a series of changes that occur. Now, and changes to the joints can occur as early as the third decade of life, or the 30s. Let's see if I can get rid of that now. But they are more prevalent and more noticeable to the patient at around age 50 or 60. So we do see an increase of symptoms with age. And speaking of risk factors, let's get into that a little bit. So the typical patient that presents with osteoarthritis symptoms is older in age, about 50 to 60 years, female gender, and obesity. And the reason that I'm going to kind of put that arrow there, I know I like stars. Let me see if I can find a star. There. Everybody likes those better anyway. And get rid of that. Okay, so I'm going to put a star on obesity because obesity is one of the major modifiable risk factors for osteoarthritis. And often losing weight will improve symptoms. And, you know, if changes are occurring early, really prevent the onset of symptoms. Another risk factor is any activity that puts stress on the joints. Running, jogging, high impact activities, any high impact sports, or occupations that require a lot of repetitive motions, manual labor. So those are some of the main risk factors. And remember that your main modifiable risk factor is going to be obesity. Obesity is defined as a BMI greater than 30, just so you remember that. So when we're assessing the patient that may have osteoarthritis who's complaining of joint pain, we want to know as much as we can about the pain. Usually that pain and inflammation with osteoarthritis is pretty well localized. It's confined to certain weight-bearing joints. It's not joint pain all over the body, which would be more indicative of rheumatoid arthritis. It has a gradual onset. People first notice some soreness and stiffness with activity, gradually gets worse over the years until it can be quite disabling. You may see limited range of motion in some joints. The knee joint, the hip joint may have limited range of motion because of joint pain. The patient may state that they can no longer perform certain activities of daily living. Now, if it's a weight-bearing joint such as a knee or a hip, it might interfere with walking. If they were runners, it might interfere with their exercise pattern. It may interfere with standing for periods of time, stair climbing, climbing up uneven surfaces. So those are things you might want to assess. And if, of course, if it's an upper extremity, you want to assess, do they have problems getting dressed, tying shoes, opening jars. As people get older, we may have to help them with some of those ADLs if they have osteoarthritis. The inflammation with osteoarthritis is generally, like I said, well localized, and that's one of the little differential signs as opposed to rheumatoid arthritis. We also see the Heberden's nodes and Bouchard's nodes. I'm going to get a picture of that. And they affect the phalanges of the hands. There you go. The distal phalange is this one. Here. That's your Heberden node, and your Bouchard's nodes are your proximal, that first knuckle. So the furthest knuckle, the distal interphalangeal joint, is the Heberden's nodes. It's just that swelling and like knobbiness. And then the Bouchard's node is your proximal. And let me just kind of clean that up for you. Okay, so according to your book, arthrocentesis is really not a good test for osteoarthritis, although it can differentiate between rheumatoid arthritis and osteoarthritis if there's a problem. Generally speaking, blood tests are not really good indicators. With rheumatoid arthritis, you'll see things like a white blood cell count. Because of the general inflammation, you might see a higher ESR. But in osteoarthritis, you don't generally see those things. What you will see are changes on X-ray. So let me pull that up for you. And here is an arthritic hip on the left and a normal hip on the right. Let me blow that up a little bit. Now, some of these things I find, honestly, a little bit harder to see than obviously the radiologist did, but that's why he gets the big bucks. So in the normal hip, you see the articular surfaces have that nice space in between. I can try and point it out and not, I mean, his arrow probably shows you a little better than mine, but his or hers, we don't know. That there's some synovial fluid in there, and the joints don't look distorted. It looks like there's normal thickness of the bone or normal bone density, and I don't see any roughness. But over here on the right, on the left, excuse me, there is no joint space. I don't see any like gray, dark gray line there. It's all pretty much whited out where the surfaces rub right against each other. Now, in the picture, the notation says that there are cysts noted in the bone of the femur head, like an osteophyte might make. I don't really see that. Maybe I just need a clearer picture. But obviously somebody did. The person who read the x-ray did find those osteophytes, those little bone spurs. Now what I do see is the thickening of the bone, the abnormal thickening right here on the head of the femur and the acetabulum. And that is that subchondral bone, the bone that is right underneath the cartilage, that gets thicker as a result. So let's see. Let me kind of get rid of that. Okay, and additionally, you might see some joint effusion, but not usually as much as you would see in other joint disorders. And there's no fever, there's no white count, there's no, no abnormal white count. It's really, you're just seeing localized joint damage. There are some ways that we can promote health and encourage lifestyle modification, and one of these is to encourage the patient to use anything that's going to spare their joints. If they're working in fields where they're using a lot of repetitive motions, we can try and encourage them to take breaks or use labor-saving devices. If they're engaging in any high-impact recreational activity like running or anything that is stressful on the joints, we might encourage them to try something a little lower in impact. Certainly maintaining a healthy weight is very, very important for people. The more weight you carry around, the more stress you put on your joints. And have people wear well-fitting shoes with good cushioning, especially if they're going to be doing an exercise activity. Will spare some of the wear and tear on the joints. So medical management of osteoarthritis is really aimed at improving the symptoms and the mobility and function. So you're going to try and improve pain and stiffness in the joint, and you're going to try and restore as much range of motion and function as you can to that patient. So going from roughly the least invasive to the most invasive, we'll start with physical and occupational therapy. And this is a pretty good option for a lot of people who are in some pain and have some stiffness and loss of range of motion. Physical therapy will help restore that range of motion and also help strengthen the muscles around the joints to give that joint extra support. And that can prevent the progression and decrease a lot of the symptoms. Exercise is a really good treatment for osteoarthritis given that it's not stressful to the joints. So strengthening exercises and lower impact exercises are good. Occupational therapy is good for people who have osteoarthritis in their wrists and hands. It can help them with activities of daily living. If physical therapy can't restore the mobility, occupational therapy will help people function at the highest level that they can. So after physical and occupational therapy, we'll talk about orthotics. And orthotics can be anything from a simple support in your shoe, an arch support, wedges in the shoes, special braces or little supports, splints. People have wrist splints, knee braces, those kind of things. And they just add a little bit of support to that joint and decrease some of the stress. So that is something that benefits a lot of people with osteoarthritis, especially if they're exercising. You'll see people might wrap the knee with something or might put one of those flexible knee braces on to give that joint a little bit more support. Now these are some complementary or alternative treatments. They call it CAM, complementary alternative medicine. And yoga has a lot of literature that supports it for people with osteoarthritis, given that the patient exercises within their limitations, doesn't try to overstretch or overstress that joint in any way. But yoga can help promote flexibility and strength and slow the progression of osteoarthritis and relieve a lot of the symptoms. Massage can be used to decrease stiffness and pain. TENS unit, I think we talked about that when we did basic human needs and we talked about pain control. It's a little unit that delivers electrical stimulation, and it sort of is a counter stimulus. Remember with the gate control theory, what happens is that the brain can only interpret so many signals at once from a nerve. So if you compete with the pain signal by providing something like a TENS unit, very often that patient can get some relief. Other people find it very annoying, but if you've ever been to the chiropractor, they've probably given you a TENS unit, and that does decrease pain. Now, hydrotherapy or warmth is something that people with osteoarthritis can benefit from. People who can't tolerate exercise anywhere else sometimes can get in the pool, and that gentle resistance from the water, especially if it's a heated pool, will help loosen up their joints and make them feel a lot better. Herbs and dietary therapies, I'm sort of hesitant to really say this because the evidence does not suggest that it's really effective. One of the more popular treatments, glucosamine chondroitin, is a supplement that can be used by a lot of people who have arthritis and problems with their joints, but the literature really does not support its effectiveness, and it's very expensive. I mean, if people want to try that, that's one thing, but generally speaking, it is not considered effective. Now, there are other dietary therapies. Some people do what they call a low inflammatory diet, but because osteoarthritis is not caused by inflammation, it may or may not be effective for them. So things like, you'll see people take things like fish oil. They may get some of the wheat out of their diet, things that they perceive to be inflammatory in nature. They might increase. I mean, it's not going to hurt them to increase fruits and vegetables and to take a fish oil supplement it just might not be the most effective choice for them. Yoga and massage and the TENS unit and the hydrotherapy and warmth are sort of a better avenue to go in. Now, their book mentions also like copper bracelets and magnetic therapy, and as far as I know, none of those things are really proven to be very effective. So there's that. And then we get into like a little bit more aggressive therapy, although generally the therapy, the medication therapy for osteoarthritis is not very aggressive. The first therapy that's usually used is acetaminophen or Tylenol. Tylenol is safer for most older adults than your NSAIDs. And because this is not an autoimmune or inflammatory disease, the acetaminophen does usually really do well for most of these patients. Then we get into the NSAIDs. And there are selective NSAIDs and non-selective NSAIDs. The non-selective NSAIDs are like your ibuprofen, your naproxen, those kind of medications. And then we have the COX-2 inhibitors. And that's like Celebrex is one of those. Now here's the problem. Some of the NSAIDs cause GI bleeding in a lot of the people that use them. And we really, when you're dealing with an older population, don't want to cause a GI bleed if we can avoid one. They generally don't heal as well as younger folks. And when you're dealing with a chronic disease that causes pain on a daily basis, people can really overdo the NSAIDs and end up with some GI bleeding. The other problem is that, especially with the COX-2 inhibitors, but even with the other NSAIDs, there are risks to the cardiac system. And they did pull one of those meds off the market, Vioxx. I don't know if you guys remember, but there was a point in time where doctors were using Vioxx for pain quite freely, and it was causing cardiac events in older adults. So that is no longer an agent that's used widely, but Celebrex is still used. There's topical NSAIDs. I'm just going to call attention to this one. Voltaren gel. And Voltaren gel is really like a topical NSAID that you put right on the joint that's affected. And this can be effective for people, but it does have the systemic effects that all the other NSAIDs do. Remember, even ibuprofen raises blood pressure in people. If it's an occasional use, that's one thing, but it's really something that you want to make sure that your patient understands before they start taking Motrin around the clock every day. And definitely when they're taking any over-the-counter medications, their physician needs to know. So when you're doing your health assessment and you're taking history, sometimes people will only report medications that are prescription, and they won't tell you that they're taking acetaminophen 4 grams a day, or that they're taking ibuprofen 600 milligrams 6 times a day. And this is something that their physician really needs to know. Because A, if they're in that much pain, there really probably needs to be better management of their disorder, and B, there may have some serious adverse effects from those things. Voltaren gel actually does have the same systemic effects. Most people think of it because it's a topical treatment. They think of it like Aspirin cream, and it's just not. It's, powerful medication. It can be very effective. While we're on the subject of topical treatments, we can talk about things like capsaicin. And capsaicin causes that counter irritation that activates that gate control theory of pain. And things like Icy Hot or Biofreeze, so those mentholated creams. Those things can sometimes be effective for people. It's important for people to know that if they are using capsaicin, not to use a heating pad at the same time. That's going to cause serious irritation to the skin and sometimes like a chemical burn. And it's the same thing with your mentholated gels and creams. You want to make sure that they're not using heat with those, because they will have skin irritation, possibly skin breakdown from those things. Aspirin cream is another one, and I believe It is something that people can get over the counter. Again, the same cautions apply. One other thing under medications that can be tried are cortisone. Excuse me. People can get cortisone injected right into the inflamed joint. And this is a temporary fix. It usually lasts for about 6 months. After that point, it may wear off and they might need another cortisone injection. Your book also mentions opioid pain medication, but I would think that for most people with osteoarthritis, that would be reserved for very severe cases or very severe episodes of pain. You would probably want to encourage more effective pain management for that person, including physical therapy and non-pharmacological treatments. And lastly, when we talk about the medical management of arthritis, a last resort can be an arthroplasty, and this is your joint replacement surgery. When this is really severe, sometimes this can give the patient the best function and mobility and decrease in pain. But it is a serious procedure, which we are going to talk about. So the patient really should be in as healthy a condition as possible before they have this procedure. Okay, so now we're going to talk about osteoarthritis and the nursing process. So when you're making a care plan for this person, obviously one of your priorities is going to be pain. That's usually what brings the person in to see a healthcare provider. It may be the reason that they've decided to have a hip replacement or knee replacement. But somebody who has pain related to degenerative joint changes needs that pain addressed, whether through non-pharmacologic strategies such as weight loss or maybe exercises or, warmth or, physical therapy that's aimed at relieving that pain. That's going to be your priority. And a lot of that is going to depend on education. So I like this one here, deficient knowledge. Although some people prefer like the readiness kind of diagnoses, like readiness for enhanced learning or enhanced self-care or whatever. Check your book for a little more knowledge with that. I like deficient knowledge related to progressive disease process. Deficient knowledge related to appropriate use of pain medications. Deficient knowledge related to strategies to decrease pain and stiffness. So patient teaching is also going to be an important focus of your care plan with this individual. Impaired mobility. Now it depends on how impaired they are, how big a priority this becomes. Obviously, if they can't maneuver stairs and they're limping all the time and they can't walk, they can't do the things that they normally do, impaired mobility takes a higher priority. And so for that, you're going to do some collaborative intervention with your physical therapist. You may have to teach the patient, again, that's deficient knowledge, to use assistive devices such as canes or walkers. You're probably going to teach them some strategies to decrease the number of times that they need to be mobile. That goes with activity and tolerance, really. But in order to increase their mobility, you're probably going to need to work with a number of other providers. You may have to remind that patient to use their orthotic devices. If they have arthritis in their weight-bearing joints, their knees or hips, they may need that knee brace. They may need that walker. So those are some good priority diagnoses. Activity intolerance is really, again, intersperse periods of activity with rest. Teaching that patient that exercise is best early in the day before they have intense pain, and helping that patient determine when they're going to time their activities. Ineffective coping could be something that you see in a patient. You really have to assess your patient to see if this fits. But if they're having a really hard time because they can't work, they used to be on their feet all day long and now that hurts their knees too bad, or maybe they have some osteoarthritis of the spine and that limits what they can do and they don't really, they can't do the things they enjoy. This could cause some ineffective coping. Now, self-care deficit, You're going to see this with patients who can't tie their shoes, open jars, things like that. So maybe you want to work with OT, maybe you want to help them get some devices that help them do a better job, or maybe you just want to assist them with their activities of daily living. So those are some diagnoses and interventions that work for osteoarthritis.